Do you know what the NICE guidance is for the prevention of type 2 diabetes? And do you find reading about it on their website a tedious experience? Well, if that's the case, you're not the only one, and you're definitely in the right place, because in this video I will be telling you about the NICE Guideline PH38, also called Type 2 Diabetes Prevention in People at High Risk. Thank you for watching and welcome to the NICE GP YouTube channel, bringing you medical information and NICE guidance from a primary care perspective. My name is Fernando Florido and I am a GP in the United Kingdom with an interest in type 2 diabetes. Without further preamble, let's go straight in. This guideline was first published in 2012 and it was last updated in 2017. As ever, all information is correct at the time of recording and it has been collected directly from the NICE website. This video will focus on the clinical management rather than the administrative or commissioning considerations, which have been removed. This guideline covers how to identify adults at high risk of type 2 diabetes. The recommendations in this guideline can be used alongside the NHS Health Check programme. Firstly, a risk assessment of the patient is required. General practitioners and other health professionals should implement a two-stage strategy to identify people at high risk of type 2 diabetes and those with undiagnosed type 2 diabetes. First, a risk assessment should be offered. Second, where appropriate, a blood test should be offered to confirm whether people have type 2 diabetes or are at high risk. Also, service providers should offer validated self-assessment questionnaires or validated web-based tools, for example, the one found on the Diabetes UK website. The information should be up-to-date and provided in a variety of formats. It should also be tailored for different groups and communities. For example, by offering translation services and information in languages used locally. Where risk assessment is conducted by health professionals in NHS venues outside general practice, for example, community pharmacies, the professionals involved should ensure that results are passed on to the person's GP. Then, general practitioners should keep records of all risk assessment results to ensure appropriate follow-up and continuity of care. Where self-assessment is offered in community venues, health professionals and community practitioners should encourage people with an intermediate or high-risk score to visit their GP to discuss how to manage their risk. Those at high risk should be offered a blood test by their GP. We should encourage the following groups of people to have a risk assessment. All eligible adults aged 40 and above, except pregnant women. People aged 25 to 39 of South Asian, Chinese, African Caribbean, Black African and other high risk Black and minority ethnic groups, except pregnant women. Also, the NHS Health Check programme is for people aged 40 to 74 who are not on a disease register and have not been diagnosed with coronary heart disease, hypertension, AF, stroke, TIA, type 2 diabetes or kidney disease. They will be treated and managed using established healthcare pathways. People who are less likely to attend a GP surgery should be encouraged to go elsewhere for a risk assessment. Possibilities include community pharmacies, dental surgeries, NHS walk-in centres and opticians. Assessments may also be offered in community venues. We should also advise people with type 2 diabetes to encourage family members to have their risk assessed. Now, there are two stages in the risk identification. In stage 1, general practitioners and other primary healthcare professionals should use a validated computer-based risk assessment tool to identify people on their practice register who may be at high risk of type 2 diabetes. The tool should use routinely available data from patients' electronic health records. If a computer-based risk assessment tool is not available, they should provide a validated self-assessment questionnaire. For example, the Diabetes Risk Score Assessment Tool. This is available to health professionals on request from Diabetes UK. General practitioners and other primary healthcare professionals should not exclude people from assessment, investigation or intervention on the basis of age, as everyone can reduce their risk, including people aged 75 years and over. Pharmacists, opticians, occupational health nurses and community leaders should offer a validated self-assessment questionnaire to adults aged 40 and over, people of South Asian and Chinese descent, aged 25 to 39, and adults with conditions that increase the risk of type 2 diabetes other than pregnant women. Or they should tell people how to access specific validated online self-assessment tools such as the Diabetes Risk Score featured on the Diabetes UK website. Particular conditions can increase the risk of type 2 diabetes. We will repeat this again: cardiovascular disease, hypertension, obesity, stroke, polycystic ovarian syndrome, a history of gestational diabetes and mental health problems. People with learning disabilities and those attending accident and emergency, urgent medical admissions units, vascular and renal surgery units and ophthalmology departments may also be at risk. NICE Guidelines on non-alcoholic fatty liver disease notes that it increases the risk of type 2 diabetes. People with high risk score should be advised to contact their GP or practice nurse for a blood test. The aim is to check if they have type 2 diabetes or to confirm their level of risk and discuss how to reduce it. All providers of risk assessment should discuss with those attending for a type 2 diabetes risk assessment how to prevent, delay the onset of the condition. This includes being more physically active, achieving and maintaining healthy weight, eating less fat and eating more dietary fibre. They should also tell people where to get advice and support to maintain these lifestyle changes in the long term. In stage 2 of the risk identification process, trained healthcare professionals should offer venous blood tests, that is, either a fasting plasma glucose or an HbA1c, to adults with high risk scores. They should also consider a blood test for those aged 25 and over of South Asian or Chinese descent, whose body mass index or BMI is greater than 23. The aim is to determine the risk of progression to type 2 diabetes. For example, a fasting plasma glucose of 5.5 to 6.9 millimole per litre, or an HbA1c level of 42 to 47 millimole per mole, or 6 to 6.4% indicates high risk. Another aim is to identify possible type 2 diabetes by using fasting plasma glucose, HbA1c, or an oral glucose tolerance test according to the WHO criteria. When it comes to matching possible interventions to the identified risk, the following will apply. For people at low risk, that is, those who have a low or intermediate risk score, we must tell the person that they are currently at low risk, which does not mean that they're not at risk or that the risk will not increase in the future. We will offer them a brief intervention advice. As part of this brief advice, we will discuss people risk factors and how they could improve their lifestyle, reduce overall risk, and we will offer encouragement and reassurance. We will offer verbal and written information about culturally appropriate local services and facilities that could help them change their lifestyle. Examples could include information support to, for example, improve their diet, including details of any local markets offering cheap fruit and vegetables, increase their physical activity and reduce the amount of time spent being sedentary, including details about walking or other local physical activity groups and low-cost recreation facilities. The information should be provided in a range of formats and languages. For people with a moderate risk, that is a high risk score, but with a fasting plasma glucose less than 5.5 millimole per litre, or an HbA1c of less than 42 millimole per mole, or less than 6%, we will offer the following advice. We will tell the person that they're currently at moderate risk and their risks could increase in the future. We will need to explain that it is possible to reduce the risk. Briefly, we will discuss the particular risk factors, identify which ones can be modified, and discuss how they can achieve this by changing their lifestyle. We will also offer them a brief intervention to help them change their lifestyle. We will give information about services that use evidence-based behavior change techniques that could help them change, bearing in mind the risk profile. Services cited could include walking programs, slimming clubs, or structured weight loss programs. We will discuss whether they would like to join a structured weight loss program, and we will explain that this would involve individual assessment and tailored advice about diet, physical activity, and behavior change, and we will let them know which local programs offer this and where to find them. Now, for people confirmed as being at high risk, that is a high risk score and fasting plasma glucose of 5.5 to 6.9 millimole per litre, or an HbA1c of 42 to 47 millimole per mole, or 6 to 6.4%, we will do the following. We will tell the person that they're currently at high risk, but that does not mean necessarily that they will progress to type 2 diabetes. We will explain that the risk can be reduced, and we will briefly discuss the particular risk factors, identify which ones can be modified, and discuss how they can achieve these by changing their lifestyle. We will offer them a referral to a local, evidence-based, quality-assured, intensive lifestyle change program, and in addition, we will give them details of where to obtain independent advice from other healthcare professionals. For people with possible type 2 diabetes, that is, a fasting plasma glucose of 7 millimole per litre or above, or an HbA1c of 48 millimole per mole, or 6.5% or above, but no symptoms of type 2 diabetes, we will do the following. We will carry out a second blood test. If type 2 diabetes is confirmed, we will treat this in accordance with NICE Guideline managing type 2 diabetes. If type 2 diabetes is not confirmed, we will offer them a referral to a local quality-assured intensive lifestyle change program. For people with a high-risk score who prefer not to have a blood test or who do not use primary healthcare services, we must discuss the importance of early diagnosis to help reduce the risk of long-term complications. We will use our clinical judgment based on the person's risk score to decide whether to offer them a brief intervention or a referral to an intensive lifestyle change program. When it comes to reassessing the risk, we will keep an up-to-date register of people's levels of risk and introduce a recall system to contact and invite people for regular review using the two-stage strategy. We will offer a reassessment based on the level of risk, and we will use our clinical judgment to determine whether someone might need to be reassessed more frequently based on their combination of risk factors such as their body mass index, relevant illnesses or conditions, ethnicity and age. For people at low risk, that is with a low risk or intermediate risk score, we will offer to reassess them at least every 5 years to match the timescales used by the NHS Health Check programme, and we will use a validated risk assessment tool. For people at moderate risk, that is a high risk score, but with a fasting plasma glucose of less than 5.5 millimole per litre, or an HbA1c less than 42 millimole per mole, or 6%, we will offer to reassess them at least every 3 years. Finally, for people at high risk, that is a high risk score and a fasting plasma glucose of 5.5 to 6.9 millimole per litre, or HbA1c of 42 to 47 millimole per mole, or 6 to 6.4%, we will offer a blood test at least once a year, preferably using the same type of test. We will also offer to assess their weight or BMI. This includes people without symptoms of type 2 diabetes whose first blood test measured fasting plasma glucose of 7 millimole per litre or above, or an HbA1c of 48 millimole per mole or 6.5% or greater, but whose second blood test did not confirm a diagnosis of type 2 diabetes. At least once a year, we will also review the lifestyle changes people at high risk have made using their review to help reinforce their dietary and physical activity goals, as well as checking their risk factors. The review could also provide an opportunity to help people restart their efforts if lifestyle changes have not been maintained. In terms of content, intensive lifestyle change programs should offer encouragement to help people undertake at least a level of physical activity that is in line with government recommendations, gradually lose weight to reach and maintain a BMI within the healthy range, increase their consumption of whole grains, vegetables and other foods that are high in dietary fibre, reduce the total amount of fat in the diet and eat less saturated fat. In these programs, established behavior change techniques should be used. For example, using motivational interviewing, goal setting, or prompting participants to set achievable and personally relevant short and long-term goals. For example, to lose 5 to 10% of their weight in 1 year is a realistic initial target. And prompting participants to produce action plans detailing what specific physical activity or eating behavior they intend to change, and when, where and how this will happen. They should also start with achievable and sustainable short-term goals and set graded tasks. Participants in intensive lifestyle change programs should be encouraged to involve a family member, friend or carer who can offer emotional information, planning and other practical support to help them make the necessary changes. For example, they may be able to join the participant in physical activities, help them to plan changes, make or accept changes to the family's diet, or free up the participants' time so that they can take part in preventative activities. It may be sometimes more appropriate to encourage the participant to get support from the whole family. Participants should be encouraged to use self-regulation techniques. This includes self-monitoring, for example, by weighing themselves or measuring their waist circumference, or both. They should also review their progress towards achieving their goals, identify and find ways to solve problems, and then revise their goals and action plans where necessary. The aim is to encourage them to learn from experience. In terms of raising awareness of the importance of physical activity, we need to find out what people already know about the benefits of physical activity and the problems associated with a sedentary lifestyle. Where necessary, we will provide this information. In addition, we will explain that being more physically active can help reduce the risk of type 2 diabetes, even when that is the only lifestyle change they make. In cases where it is unrealistic to expect someone to meet the recommendations of minimum physical activity, we should explain that even small increases in physical activity will be beneficial and can act as a basis for future improvements. We will need to encourage people to choose physical activities they enjoy and that fit easily within their daily lives. For example, they may choose to do specific activities such as walking, cycling, swimming, dancing or aerobics. Or they could build physical activity into their daily life, for example, by walking or cycling instead of using a car or short journeys, and by taking the stairs instead of the lift. We should encourage people to set short and long-term goals, and in addition, we should encourage them to keep a record of their activity, for example, by using a pedometer. In terms of weight management, we need to advise and encourage overweight and obese people to reduce their weight gradually by reducing their calorie intake. We need to explain that losing 5 to 10% of their weight in 1 year is a realistic initial target that would help reduce their risk of type 2 diabetes and also lead to other significant health benefits. We will motivate and support overweight and obese people to continue to lose weight until they have achieved and can maintain a BMI within the healthy range. For the general population, the healthy range is between 18.5 and 24.9. For people of South Asian or Chinese descent, the range is likely to be between 18.5 and 22.9. We should encourage people to check their weight and waist measurements periodically, and we will offer a structured weight loss program to people with a BMI of 30 or more, or 27.5 or more if the person is of South Asian or Chinese origin. Alternatively, if more appropriate, we will offer them a referral to a dietitian. General practitioners should consider offering Orlistat in conjunction with a low-fat diet to help those who are unable to lose weight by lifestyle change alone. Finally, if these weight management interventions have been unsuccessful, we will need to refer people to a specialist obesity management service. In terms of dietary advice, we will provide the information explaining that increasing dietary fibre intake and reducing fat intake, particularly saturated fat, can help reduce the chances of developing type 2 diabetes. We will need to encourage people to 1. Increase their consumption of food that are high in fibre, such as whole grains, cereals, beans and lentils, vegetables and fruit. Choose foods that are lower in fat and saturated fat, for example by replacing products high in saturated fat, such as butter, some margarines or coconut oil, with versions made with vegetable oils that are high in unsaturated fat, or using low-fat spreads. They should choose skimmed or semi-skimmed milk and low-fat yogurts instead of cream and full-fat milk and dairy products. Choose fish and lean meats instead of fatty meat and processed meat products, such as sausages and burgers. They should grill, bake or poach or steam food instead of frying or roasting. For example, choose a baked potato instead of chips. Avoid food high in fat such as mayonnaise, chips, crisps, pastries, poppadoms and samosas. Choose fruit, unsalted nuts or low-fat yogurt as snacks instead of cakes, biscuits, Bombay mix or crisps. When it comes to helping vulnerable groups, we will need to provide up-to-date information in a variety of formats. This should be tailored for different groups and communities. For example, messages could be provided in a visual, braille or audio formats. The services will also need to educate those involved in buying or preparing food in residential care, day centres and psychiatric units about what constitutes a healthy diet and how to prepare healthy meals. There are recommendations on metformin which are as follows. We will use our clinical judgment on whether and when to offer metformin to support lifestyle change for people whose HbA1c or fasting plasma glucose blood test results have deteriorated if this has happened despite participation in intensive lifestyle change programs, or they are unable to participate in an intensive lifestyle change program, particularly if they have a BMI greater than 35. This recommendation is based on standard release metformin. Some standard or modified release metformin products have also extended their marketing authorizations to include reducing the risk of or delaying the onset of type 2 diabetes in adults who are at high risk are progressing towards type 2 diabetes despite intensive lifestyle changes for 3 to 6 months. In this respect, we will discuss with the person the potential benefits and limitations of taking metformin. We will need to explain that long-term lifestyle change can be more effective than drugs in preventing or delaying type 2 diabetes. We will need to encourage patients to adopt a healthy diet and be as active as possible. Where appropriate, we will stress the added health and social benefits of physical activity. For example, point out that it helps reduce the risk of heart disease, improves mental health, and can be a good way of making friends. We will also advise them that they may need to take metformin for the rest of their lives and inform them about possible side effects. We will check the person's renal function before starting treatment, and then twice yearly or more often if they are older or if deterioration is suspected. We will start with a low dose, for example 500 milligrams once daily, and then increase gradually as tolerated to 1,500 to 2,000 milligrams daily. If the person is intolerant of standard metformin, consider using modified release metformin. We'll prescribe metformin for 6 to 12 months initially, monitoring the person's fasting plasma glucose or HbA1c levels at 3 monthly intervals and stopping the drug if no effect is seen. There are also recommendations on Orlistat, which are as follows. We will use our clinical judgment on whether to offer Orlistat to people with a BMI of 28 or more as part of an overall plan for management obesity. We will also discuss the potential benefits and limitations of taking Orlistat and its side effects, and advise the person to follow a low-fat diet that provides 30% of daily food energy as fat, distributed over 3 main meals a day. Ideally, we should offer information and regular support from a dietitian. We should also agree a weight loss goal with a person and regularly review it with them. We will need to review the use of Orlistat after 12 weeks. If the person has not lost at least 5% of their original body weight, we will use our clinical judgment to decide whether to stop the Orlistat. However, like with adults who have type 2 diabetes, those at high risk of the condition may lose weight more slowly than average, so less strict goals may be appropriate. We should use Orlistat for more than 12 months, usually for weight maintenance, only after discussing the potential benefits, limitations, and side effects with the person concerned. This is the end of this video and the summary of the guideline. If you have found it useful, please make sure that you hit the like and subscribe buttons. There is also a podcast version in the Diabetes in Primary Care podcast, which you can find on your favorite podcast provider. I will leave a link in the description below, and you will also be able to find links there to the full NICE guideline. Thank you for watching. Goodbye.